Please listen carefully.
Hello, Team Anaesthesia. Welcome to GasGasGas. This is the best anaesthetic science podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. Now, you might be in the gym right now, commuting, or ironing your scrubs, and there's no judgment here. GasGasGas will prime your brain for the monsoon of knowledge you need to imbibe. But regardless, the revision is eventually going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Now remember to check out the website, that's gasgasgas.uk. There are show notes there with all the detail, plus links to foundational reference papers and anything else useful I find for you guys. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, this episode is going to explore halothane. This is an important anaesthetic gas to understand when you're studying for the diploma in anaesthesia, or in fact the Fellowship of the Faculty of Anaesthetists, the FFA exam in Great Britain. Admittedly, you might be sitting this if we were in 1960, but nevertheless, halothane kind of marks a big shift in anaesthetic agents from those that had a proclivity for exploding and those which are less inclined, which is a big pivot in safety, and the reason why we have anti-static shoes still, amongst other reasons, I'm sure. With the advent of halothane, smoking was back in fashion, static was fine, and sizzling tissues whilst wafting halothane around the place in a liberal manner was all the rage. Gone were the explosive diethyl ethers, the acetylenes, the trichloroethylenes, and the cyclopropane anaesthetics of the 1950s, and a world of fewer explosions, but perhaps possibly maybe a greater prevalence of post-operative liver distress. I think it's always worth understanding where we've come from to have a better appreciation of where we are today. With the evolution of anaesthesia beginning from early humankind in the African Rift Valley system, which was well known for its research output and citation rates. It all began with hominids such as Australopithecus roaming the savannas of this Rift Valley system, clonking each other on the head, to Homo sapiens with their ether, to Homo halothanus, and nowadays Homo propopholopithecus, which we are all fortunately members of. I'm just imagining the evolutionary progression of anaesthetists. Will it be Homo magneto-obliterans next? I don't know. Anyway, let's get on with it. Halothane. What are the physicochemical properties of halothane? Well, it's called halothane for a start. Its brand name, once upon a time, was fluothane. That's because of the fluorine. And its class is a halogenated hydrocarbon. The halogenation aspect of it is really the shift that made this thing stop exploding from its non-halogenated hydrocarbon volatile pals. It contains 3 fluorines, 1 bromine, and 1 chlorine. It was first synthesized in 1951 by someone called Dr. Suckling at ICI, that's Imperial Chemical Industries. Now, Imperial Chemical Industries was owned by a British lord that was involved in making lots of explosives and other useful or non-useful things in several of the wars, but it pivoted to making other chemicals. And halothane saw its first clinical use really from 1956, with research coming out of Manchester Royal Infirmary. So go UK, inventing and bringing to market yet another thing. Once upon a time, now we don't. Halothane is an enantiomer. So there's an R and an S halothane. It is presented as a clear, colourless, non-flammable liquid with a sweet smell. Its commercial preparation contains 0.001% thymol. This stops liberation of bromine. Thymol is derived from thyme, that delightful herb. What about the stability of halothane? So ultraviolet light and halothane do not mix. It is decomposed into free chlorine and phosgene. Now, you might have heard of phosgene. Doesn't sound good for you, does it? Phosgene is a colourless, non-flammable gas, and whilst it is useful from a industrial chemical application perspective, was also a chemical weapon in World War I. In high concentrations, it's very irritant to the airways and causes pulmonary edema, so you wouldn't want to spill halothane on the floor and not bother cleaning it up again. It also liberates free chlorine. If you can think free chlorine, that's probably not good for you, and you're right. Again, free chlorine gas was used as a chemical weapon. It again triggers pulmonary edema, but there have also been accidental chemical gas exposure events when people have been mixing cleaning agents which inadvertently liberate chlorine. I think there's a BBC News article in the show notes that describes someone trying to alter the chemical additives in a hotel pool and then made a lot of people very sick. Halothane is also readily soluble in rubber, so it was often found to soak into those old-fashioned black rubber mask anaesthetic circuits. And in the presence of water vapour, it gets about attacking brass and aluminium and lead. Also, halothane is bad for the ozone layer because of the chlorine and bromine that gets liberated up there. Doesn't sound like I'm selling it to you right now, does it? Its molecular weight is 197.4 grams per mole, which is somewhat similar to most of the volatile anaesthetics. Halothane boils at 50.2 degrees. This is a bit less than sevoflurane, but has a higher saturated vapour pressure. Halothane's saturated vapour pressure is 32 kilopascals at 20 degrees C, whereas sevoflurane is at 22.7. So in of itself, halothane is really quite potent. Okay, so to achieve 1 Mach of halothane, your end tidal halothane concentration needs to be 0.75%, which is really low. Remembering desflurane is 6.6, sevoflurane hovering around the 2.2 to 1.8, and isoflurane 1.2. So you can therefore infer that halothane is really quite potent. And it has an oil-gas solubility coefficient of 220, which is proper high. Remember, the oil-gas solubility partition coefficient of sevoflurane is 47. However, halothane's blood gas solubility coefficient is 2.5. Compare that to the 0.69 of sevoflurane. So it is really quite soluble in the blood. That means it takes time for halothane to achieve sufficient concentrations in the body to induce anesthesia. And therefore, you would also infer it takes time to wear off. So really potent, but quite soluble in the blood, so it takes a while to work. What about the side effect profile? Because we know it works by altering how GABA A receptors modulate your neurons in your noodle. We don't know how that bit turns off your consciousness, but you can kind of infer that, well, if it's turning your neurons off, then therefore you probably are rendered unconscious because we don't understand consciousness. Right. Side effect profile of halothane. This causes a lot of mischief, actually. The headline is it causes ventricular and bradyarrhythmias, which are exacerbated by homeostatic derangements like hypoxia and hypercapnia, as well as sympathetic nervous system excited states or the administration of adrenaline. So imagine you're trying to do a gas induction on someone who's about to fall off that cliff edge due to sepsis with halothane, and they are riddled with catecholamines, desperately trying to maintain a blood pressure, then you might end up in VT. Now, I've never used halothane. I certainly never used halothane in that situation. This is hypothetical. I'd love to find out if that was true. If anyone knows anyone who has used halothane, let's hear it. It would be great. Anyway, halothane messes with your myocardium. It is a negative chronotrope. So anyone who's under a halothane anaesthetic will have a slower heart rate. This is because halothane stimulates your vagal nerves, slowing your sinoatrial node. It has a direct myocardial depressant effect. Calcium influx inhibition is blamed here. Dromotropy-wise, your AV node is also depressed. Your AV node has vagal inhibition on it as well. What about bathmotropy? Remember, this is the excitability of your myocardium. And we can say that in states of homeostatic derangement, it makes your myocardium a bit more excitable, hence the ventricular arrhythmias. What does it do to your systemic vascular resistance? It drops it by around about 15%. Therefore, if you take the sum of all this, you see a dose-dependent reduction in cardiac output. It doesn't have a terribly significant effect on your coronary arteries. So respiratory-wise, remember, you can split this into things that directly act on the lung, the parenchymal effects, and then those that act on the respiratory centre. So you breathe quicker and you breathe shallower with halothane anesthesia. Again, from a parenchymal perspective, it inhibits your hypoxic pulmonary vasoconstriction. This can cause the lungs to accept perfusion in parts of the lungs that aren't ventilated. So you might end up with some shunt fraction going up. Halothane is a bronchodilator. It inhibits histamine release, and it is non-irritant, and it's actually very lovely to induce someone from a gas induction perspective with halothane. What about its CNS effects? So it raises your intracranial pressure, and it does this because it dilates your cerebral vasculature. As with all volatile anesthetic agents, expect to see a drop in your CMRO2. This is the metabolic rate of oxygen consumption of your cerebral tissues. It's unclear if halothane does anything to your seizure threshold, and it's going to make you nauseous and barfy because all volatile anesthetics do. So what about GI side effects. Causes reduced salivation, actually, which is handy. Remember, it stimulates your vagus nerve, your parasympathetics. It slows your GI motility, and it does reduce splanchnic blood flow. From a renal perspective, it reduces renal blood flow by about 40% measured, and your GFR might go down by about 50%. So you could imagine like a prolonged halothane anaesthetic, might upset the kidneys quite a bit. Now, from an obstetrics perspective, like all other volatile anaesthetic agents, it creates uterine atony or hypotony. It is a trigger of malignant hypothermia. And remember, the end point of toxicity is cardiovascular collapse, but also probably other dysrhythmias first. There are a number of interesting metabolic side effects to halothane. It increases release of thyroxine and growth hormone. It reduces your circulating noradrenaline concentrations. It inhibits nitric oxide synthase. And this is an enzyme that enables vascular dilation due to nitric oxide. If halothane did not do this, you'd probably see an even greater drop in blood pressure with it. And halothane inhibits leukocyte phagocytosis. Now, there's loads of side effects there. What are they really going to ask you in the exam? If halothane comes up in the exam, it's either going to be something to do with the fact that it causes VF or VT or bradycardias, especially in a hypoxic person, or thinking about the hepatotoxicity of halothane, which we're going to get to in a minute. But it is perhaps somewhat important for one or two of you folks to know about halothane, because you might end up using it. It is still a volatile anaesthetic agent that is used around the world, especially in healthcare systems with fewer resources, because it's cheap. And I just imagine, what if there was an apocalypse? You wouldn't be a very useful anaesthetist if all you could use was Tiva. Anyway, I'm just imagining someone with like zombies knocking on the door, trying to put the height and the weight and stuff and the age into a pump to try and do an anaesthetic to chop someone's leg off. It would just, maybe we'll go back to Australopithecus and bonk people on the heads. Right, halothane pharmacokinetics. I couldn't tell you if there's a first-pass metabolism. It is quite heavily metabolized by the liver, so arguably, if you were to drink it, you would probably clear a reasonable amount with your liver. Wouldn't recommend. Distribution-wise, it's really soluble in blood. Naturally, it's going to prioritize high cardiac output areas first as it's shifting around, but it will take a while to reach concentrations due to that blood gas solubility that's really quite high. Metabolism, this is really where you're going to earn your money. The range of agent metabolized is described as either 20 to 25%, but perhaps up to 50% of halothane is metabolized by the liver. And remember, like SIBO's 3 to 5%, isoflurane is 0.2%. But we're interested because in normal circumstances with the liver, metabolism of halothane is via an oxidative pathway, and it's our dear friend CYP450-2E1. And you end up with oxidation and dehalogenation, leading to the creation of trifluoroacetic acid. Try and remember that, trifluoroacetic acid. And then some other molecules, which I'm not going to list, but it's all on the website. And then perhaps 1% of halothane is reduced by CYP2A6 and 3A4. The reduction liberates fluorine in a number of different manners, and these can end up undergoing lipid peroxidation, and they can be quite toxic. Now, when you have a hypoxic patient, the pathway leans toward reduction because there's perhaps less oxygen available in those zones of the liver. So a hypoxic liver processes more halothane to something that is more toxic, and that leads to increased hepatic upset. We're going to go into halothane hepatotoxicity in a second, but I want to point out first that despite us knowing that this certainly happens, when it first came out, they didn't know it happened, and we still don't truly know the absolute mechanism for why this comes about. Halothane elimination, 60 to 80%, depending on whatever your liver clears, is exhaled, but it takes 3 weeks for all the metabolites to get fully cleared out of a human. And now they recommend that if you've had a halothane anaesthetic, you don't go and have another halothane anaesthetic next week. And actually, you're better off waiting 3 to 6 months between halothane anaesthetics to reduce the chances of liver injury. That might not be so possible if your only anaesthetic agent is halothane. Halothane hepatotoxicity. It was actually first noted with volatile anaesthetics that chloroform could cause a jaundice. Ether didn't seem to be a problem. And there are 2 types of halothane hepatitis. There's type 1, and this is a reversible, transient transaminitis. It's subclinical. The range of who gets it is quoted to be really broad, 1 in 20 people to 1 in 3 people. You see a rise in your liver enzymes about 1 to 2 weeks after exposure, and the blame here is covalent bonding of metabolites to cellular components, which occurs more likely in hypoxic conditions and is self-limiting. And if you were to desire a halothane hepatitis, type 1 is the one you would like. Type 2 halothane hepatitis is a fulminant necrotic disaster with a 50 to 75% mortality rate, and patients present differently. They have signs. They end up initially with a sort of prodromal, pyrexial, rash, achy joint pain type event, which can precede a jaundice by up to a month. Without transplant, it's not looking good. Who gets it? So 1 in 80 to 200,000 kiddies, so actually a wee kiddie having a halothane anaesthetic is much less of an issue, which is 1 in 2,500 to 1 in 35,000 adults to 35,000. So it's still reasonably rare. Now, if you've been pre-exposed to halothane, you have a greater risk. The more exposures, the more risk. There may be a genetic element, as if you have a family history of halothane hepatitis, you have an increased risk. So what is the pathophysiology of this fulminant hepatitis? Noting, folks, that the exact mechanism is not entirely clear, but you can infer from a pyrexia, a joint pain, a rash, that sounds like an immune system thing. And the basis is that it is an immune-mediated reaction versus hepatocytes. And there is a metabolite from halothane metabolism that covalently bonds to a liver protein. And this has been labelled a hapten, Hapten, not haptan, which is a different thing, hapten. The offending molecule may well be this trifluoroacetyl chloride molecule that the CYP2E1 mediated metabolism has created. This seems to bind to hepatic proteins, forming a molecule that your immune system considers an antigen. You then end up producing anti-trifluoroacetyl antibodies, which are blamed for the wreckage. And you can test people for anti-TFA antibodies if your lab will do that. I mean, I don't think the NHS labs will, because no one uses halothane. Don't even think they do so, unlike, the Isle of Lewis. Now, you do normally produce trifluoroacetyl acid, acetyl chloride, when metabolizing other volatile anaesthetic agents, mostly enflurane, isoflurane a little bit, but not much. But note, we might be metabolizing up to 50% of the halothane we're giving someone. That means that there's a lot more trifluoroacetyl chloride floating about that has to get tidied up, and that is one suggestion as to why it seems to happen. In summary, halothane, sweet smelling, contains thymol, a MAC of 0.75, so you don't need very much of it, because it's very potent with an oil gas coefficient of 220, but it's quite soluble in blood, so it takes time to hit that 0.75% end tidal. Your heart does not like halothane. It tickles it mercilessly. It'll either slow it down, or you'll end up with a ventricular tachycardia, and your liver is not amused when it comes to metabolizing halothane. The metabolite that is the chief offender is trifluoroacetyl acid, TFAA, or trifluoroacetyl chloride. However, the full mechanism of hepatotoxicity is not elicited. It is an enantiomer. It is a halogenated hydrocarbon, and it contains a bromine, a chlorine, and 3 fluorines, and it does not explode. So I was going to close this episode out with some conversation about explosions. However, it transpires that it's not just a chapter on explosions, it's an entire section on explosions in this book written by Sir Robert Mackintosh of Macblade fame. So we're going to do a whole episode on explosions and fire and flames, with perhaps some sort of Dragon Force reference somewhere. I've halfway through writing it, so we'll see you next time with that, and then we'll finish with desflurane and perhaps some dabbling with the history of all these anaesthetic agents we've spoken about, like cyclopropane and chloroform and ether, for a bit of curiosity. So have a very nice weekend, folks. I'll see you next time. Ahoy, Team Anaesthesia! You've survived yet another episode of Gas, Gas, Gas. Now, if you found it useful or harrowingly awful, please like and subscribe, drop us a star or 12, and follow with whichever podcast platform you find yourself using. Please leave a comment or ping off an email if you think I need to square something away. Now, there are a bunch of ways to support the costs of Gas, Gas, Gas. From buying me a coffee, to venturing forth via an affiliate link, to the horde of joyful SBA questions from Teach Me Anaesthetics. Those links are on the website and in the show notes. Speaking of website, definitely check out gasgasgas.uk for the show notes, diagrams, the details, the references. Now, we all know, guys, that this is a bucket of content to consume, and it is like drinking from a fire hose. So I want to finish by saying, take it day by day. Don't overcook yourself, don't freak out, and keep studying.